Where we left off last was this discussion here about how cerebral blood flow is regulated to a certain extent. It's regulated by three things: CO2, mean arterial pressure, and PaO2. Okay. So the other thing that's important for also cerebral blood flow and cerebral metabolic rate of oxygen consumption is temperature. And one of the things that we do in the operating room constantly to try to protect the brain is we try to devise different modalities basically to diminish the risk of low perfusion states. So one of the things that we want to eliminate as much as possible is getting yourself into an irreversible cellular damage state due to either anoxia, which is very tightly correlated to your oxygen consumption rate. If you have a low oxygen consumption rate, then the brain basically is not utilizing very much oxygen, and it, as a consequence, doesn't get depleted as quickly, and then doesn't go into that irreversible cell death due to lack of oxygen. Okay? So one of the things that we do is, besides putting the person into a comatose state, like we give barbiturates or benzodiazepines, we basically induce a very quiescent cellular function. We can also add to that temperature changes. In the old days, back in the 40s, before there was really a development of cardiopulmonary bypass machines, the only way that people could actually stop the heart for a prolonged period of time would be they would take these children or adults and they would put them in ice baths under general anesthesia and drive their temperature down to 17 degrees Celsius without even having a cardiopulmonary bypass machine. Okay? If you want to have, we have time, this is later on, you can get some very interesting reading about how they actually did this on somebody. And then eventually they would arrest the person around 16 degrees because they were so cold. But the heart would slow down tremendously. But they found that the brain could be protected very effectively if you could get down to the degree around 17 degrees Celsius. Below that, you get too close to freezing. And if you actually freeze a cell, unfortunately water expands, not shrinks at that point. And when it expands, the bubbles come out of the air comes out of the solution. And it causes the cellular destruction. So you don't want to freeze the cells, that doesn't help you, but you just want to make them really, really cold. So 17 degrees is where we actually take a person down to, usually in the operating room. That's really very, very cold, by the way. Okay? So you can see from this temperature that your actual cerebral metabolic oxygen consumption rate, it goes from around 5.5 when you're awake at 37 degrees, and by the time you're down to 17 degrees Celsius, pretty much all of the cortex has gone to sleep, okay, and a little bit of the brainstem is still functioning, but it's really very, very quiescent at that point. Your EEG is basically isoelectric, and you can't see any EEG activity. Now, how can that be helpful to you clinically? Well, one of the things that we have once in a while is that we have to take these people and put them down to the state quickly, but you want to sort of make sure that you're assured that's happening. So one of the things that I do in clinical is I put on a BIS monitor. Usually getting EEG monitors at 2 or 3 o'clock in the morning when you're having to do like thoracic dissections is pretty hard to find. So instead you can do is a simple monitor that we all have in the operating room, which are the BIS monitors, which basically take EEG activity from different portions of the brain and then basically incorporates it and gives you a number. And you want the BIS number to actually be what? 0. 0. Which means that there's no electrical activity. If you actually do that under normal conditions, that would be a very bad thing. That would be telling you that your brain's not getting enough perfusion to it. But in this kind of situation, you're trying to induce that state of basically shutting down the brain completely. Then you get a BIS of 0. And that's what we do right before we put somebody on cardiac standstill. The other thing that's when the student gets, we talk about this in 3 different parts of the semester, of the next 3 semesters. We begin to talk to you about neurophysiology because it ultimately becomes a critical part of your job. When you get to clinical, you don't want to have to learn it just when you get there. You want to sort of understand it pretty well by the time you get to the 3rd semester. ICP is an additional thing that we use to monitor. And what you want to think about is that we throw a lot of different terminologies when we talk about neuro. We talk about cerebral blood flow, but that's something we don't really measure. Okay? Unfortunately, it's something that we can't really easily monitor. Instead, these are all experimental things that we know they correlate to certain things like temperature, CO2, mean arterial pressure, and your oxygen tension. Okay? In addition to that, we also know that ICP impedes perfusion. Okay, remember, cerebral perfusion pressure is mean arterial pressure minus ICP pressures. Okay, some of you might have learned it in general practice as mean arterial pressure minus CVP, because under normal conditions, if you have a normal brain, CVP and ICP are almost the same. So you can switch back and forth. But when you have somebody with a diseased brain, like somebody who's been contused in their brain, somebody who's had a tumor in their brain, somebody who's getting swelling in the brain, then that no longer follows. Okay, in that way, the only way to truly monitor these people is by putting an intracranial pressure monitor. Okay, now the way we do intracranial pressure monitors has changed in the last 20 years. We used to just put in a bolt, which is you just put it in, so it was just underneath the dural. And the bad thing about it was that you couldn't do anything therapeutic, even when you saw the pressure go up. So most of the neurosurgeons now are putting in intraventricular drains. Okay, and through that intraventricular drains, we're actually measuring pressure directly. And if we have to do something therapeutically, we can drain CSF out, bring the ICP pressures down, and sort of hopefully improve the complications of this patient. Now, of course, you got to understand why your ICP is rising in the first place. And that has to do with that compliance curve we talked about last week. Once the ICP is beginning to rise, you're on the bad portion of the compliance curve, which indicates that you've got something pretty bad going on. Now, the normal ICP pressures are between 5 to 15 millimeters of mercury. What actually can induce an increase in ICP could be brain itself. The brain can actually swell. That's the most common complication associated with ischemia of the brain. Anything that injures the brain or causes inflammation of the brain causes edema to form. And edema is an enemy to you because inside of a fixed cranial vault, you have no way to expand. Okay? As a consequence, you begin to compress on the surrounding blood vasculature, and as a consequence, cause even more decrease in perfusion to surrounding structures, making the edema even worse. So it's like getting yourself into a revolving spiral that you can't get yourself out of. So increased water content in the extravascular spaces becomes a problem. Diuretic therapy may actually be indicated in those kind of patients and may help decrease the edema. Okay? The other reason that you get brain swelling can be from intracranial mass lesions such as tumors. Tumors are responsive to corticosteroids, and they're given many times for that reason. Okay? But for brain edema, corticosteroids have been ineffective, and actually most people feel they're contraindicated. The reason that they're contraindicated is not kind of intuitive for most people. It's actually because it raises blood sugar levels very quickly. Okay? So who cares about blood sugar? What's so bad about blood sugar being elevated? What's that? Well, the brain likes it, that's right. And one of the things that the brain likes about increased glucose is it consumes it. It consumes it and increases the cerebral metabolic rate of oxygen consumption. And if you have a brain partially deprived of oxygen consumption, it's going to make that cell develop going to an anaerobic state much more rapidly, and the brain can't get rid of lactic acidosis like other tissue can. It has a really hard time. The blood-brain barrier, when it's intact, basically impedes the lactic acidosis from coming out, so it becomes a highly acidic state for the brain, and then causes the actual neutralization or inactivation of the actual receptors of proteins, and then causes massive problems for you. Okay, so you really want to avoid that situation as much as possible. Okay, we have actually found that in somebody that has actually developed, let's say, coded and required CPR, if their sugar levels are elevated, their survival rates diminish significantly just simply from that fact. Okay, the brain actually will actually go into a more of a anoxic state much more rapidly because it consumes that extra glucose trying to produce more ATP for itself, even though it can't produce it because there's not enough oxygen to produce the ATP through respiratory oxidative phosphorylation. Instead, it goes into a lactic acidosis, so the acidic levels in the brain rapidly rise, and it causes huge problems in the long term. The other things that can raise ICP pressures, of course, are the blood vessels. The blood vessels can actually hemorrhage out. Okay? Hemorrhaging will go into this closed space and cause problems. The other thing that's unusual, though, is that you'll vasodilate the patient inappropriately, okay? And that can also increase the ICP. But really, that's a minor point if you think about it. It accounts for only 4% of the total surface area or total volume inside the brain. So really, blood is really a small, minor component. Okay? One of the problems that we have in the way of describing hemorrhaging, not so much hemorrhaging, where blood is going, is that if you inappropriately manage somebody, you can actually cause them to dilate excessively, and or actually cause a shunt effect where you're pulling the blood away from the brain that's ischemic, and as a consequence cause more ischemia to the brain that's already lacking perfusion. Okay. The other reason for increases in ICP would be increases in CSF, which is increasing cerebrospinal fluid. This could be from decreased absorption. This is going to occur from different forms of anesthetics, increased production, and obstruction of drainage. Most of the time, it's usually due to obstruction of drainage if you have an intracranial mass lesion, or due to brain edema, where you get actually compression of one of the ventricles, okay, or the canals, and that can actually cause a significant rise in ICP because now the CSF can't drain out and get reabsorbed. Blood, which is autoregulated through cerebral blood volume or cerebral blood flow, okay, as we described previously. Now, unfortunately, this picture gives you just what mean arterial pressure is. Let me show you what's missing on this. On the previous diagram that we showed you, I had this like this. Okay, so your mean arterial pressure is very tightly regulated between the pressures of 50 to 150 millimeters of mercury. So as long as your mean arterial pressure on a normal individual stays between 50 and 150, the blood flow stays pretty much constant. Okay? What the cerebral vasculature will do during those mean arterial pressures is it'll continue to vasoconstrict down to maintain a fixed cerebral blood flow. Okay? Once it exceeds 150 millimeters of mercury, then the blood vessels will actually begin to vasodilate. And at that point, you see an increase in cerebral blood flow at that point, which then would consequently increase the cerebral blood volume, which then increases the intracranial pressure. Okay, so one follows the other. Okay, so what you would see in clinical situations like that would just be an increase in ICP. Okay, but that goes back to what caused it. In this case, we're talking about a rapid rise in mean arterial pressure above 150. So somebody that would have a pretty significant malignant hypertension, to say the least. Okay? If you go below 150, though, the blood vessels can't vasodilate anymore, okay? And at that point, the blood volume begins to drop off, and your ICP pressures begin to fall because you're actually limiting cerebral blood flow. Now, at one time, we actually used this clinically, thinking that would be a good thing. The danger of this is that we didn't understand perfusion well then. In the 1980s, there was still discussion and argument that what was shock, okay? And shock was a lot of times was just a thought to be associated with blood pressure. And it's really not associated with blood pressure at all. You can have somebody with a completely normal blood pressure and they can still remain in shock. And actually you can kill them with Levophed, as we found out in the 1970s, 1980s. When we first started getting that medication, we started giving high dose Levophed, and we had great blood pressures, and all these people would die because they would continue having severe metabolic acidosis. If you squeeze somebody down hard enough and you don't perfuse the cells behind it, you'll get an adequate blood pressure, but you're still having the patient die because of lack of perfusion to the cells. So ultimately it came down to cellular respiration. If you don't deliver oxygen to the cells die. The same thing applies to the brain. Actually, the brain is actually much more sensitive than any other organ in your body. Okay, so by dropping off the cerebral blood flow to those patients, you're actually doing them a disservice. You may actually be worsening their edema in the long run, in about 6 hours, because you're producing more overall brain ischemia. In Birmingham and Alabama, one specific doctor said that what we're doing is wrong, and he was very controversial at the time, stating that we should actually increase perfusion, not decrease it. And he started inducing patients to be given high doses of dobutamine to drive the cerebral oxygen supply to be very high. He doubled it. Unfortunately, some studies show that it helped, and other studies show that it might put a lot of stressor on older people, and they may actually not tolerate that kind of therapy. So there's a lot of controversy on how to manage it. But what's really funny is there was no really, everybody said that the people would die at higher rates because of elevated ICP pressures, and it was found not to be the case. Okay? So and if you go back to the 1980s, even to the 1990s, our death rate from brain injuries is the same as third world countries. So once you induce a certain problem, even with high technology that we have, you can't really fix it. Now we're starting to see a little bit more improvement in survival rates because, and not only survival rates, but morbidity and mortality, because we're actually changing some of the therapies that are being given. But it's still pretty much dark ages. We need to find some way to protect the brain against anoxic injury. Some of the studies that are coming down that are kind of important that you may actually hear is you'll hear about what's called oxygen protection therapy. Okay? And some of the new things that are coming into the ICU is they're now taking patients who were arrested and now they're putting them into a hypothermic state for about 24 hours. And actually they're finding out that this is significantly improving survival and decreasing the morbidity associated with hypoxic injury. So these are things that may actually come to play eventually back in the operating room where we'll be told to induce somebody into a hypothermic state and keep them there and leave them into the recovery phase, into the ICU, so the patients can actually do better. For now, though, we're still being trained, and I'll still train you, that hypothermia is your enemy. It is. Okay? Under most surgical conditions, hypothermia is a huge problem for us in the sense that it induces a severe coagulopathy to develop. Platelets don't work. Patients will literally hemorrhage to death. If you do get hypothermic, it's the best deal to do is just to pack the person, close them up, and take them to the ICU and rewarm them, and then bring them back and then do the surgery. Because otherwise, you're just going to be bleeding from everything you touch. So, and then you have to give the person multiple units of blood, and you get into a lot of the complications associated with that. Okay. Now, one of the unfortunate things that happens when somebody does get a brain injury, such as gets hit in the head with a hammer, or gets hit, just hits the dashboard or something severe like that, is that you may get loss of autoregulation. Okay, the brain blood vessels may actually lose their ability to maintain this normal autoregulatory mechanism between the mean arterial pressure of 50 to 150. In this situation, the actual line becomes linear. Okay, so as you increase your cerebral blood flow, you will actually begin to dilate the blood vessels. So as a consequence, you see an immediate increase in ICP pressures because you don't have this autoregulatory mechanisms in place. Now, this may be only taking place in tissues that are injured, okay, or tissues that are showing signs of ischemia. And that's kind of important because that would be actually a good thing. If you had this for normal brain tissue, then the blood would be shunted from the normal tissue into a higher perfusion to the areas that are becoming ischemic. So it may be protective of the brain in the sense that we're looking actually at a normal mechanism for protection of the brain. That's still not been really well elucidated, so this is coming down the pike. We'll see in a few years. Now the next set of discussion is going to be on autonomics, okay? And this is a very important point for you to understand. If you don't understand autonomics, you'll never understand how you can actually deliver anesthetic agents and how they actually affect the body. So you really have to understand autonomics very, very well. Okay, so anytime you don't understand this area, stop me and I'll go back over it because this is one of those that are really key to what you have to do every day. Okay? The autonomics are located in two areas. They're located in the central nervous system and the peripheral nervous system. It coordinates and basically maintains a steady state among the visceral or internal organs of the body. So it regulates the glands, the smooth muscle, and cardiac muscle of your body. Now, for simple sake, okay, any nerve that comes out of the central nervous system, and the first site that it binds, the neurotransmitter that is used is acetylcholine. That holds true for autonomics as well. Okay? If you look at the autonomics, there's two sides to it. There's called the parasympathetic and the sympathetic. Okay? The parasympathetic originates usually from cranial nerves, such as cranial nerve number 10, which is the vagus. Okay? That basically originates from your brainstem, in other words. Okay? The other portion of the parasympathetics that occurs besides the brainstem is at the sacral level. Okay, so there's only two portions, one on each end of the spinal cord, the brain and the sacrum. In between that is the thoracolumbar area, which is where the sympathetics are located at. So the sympathetics don't necessarily originate from the actual brain itself, but they still do originate from the central nervous system, okay, in the sense that it's part of the integral part of the spinal cord. Okay? Now, you ask yourself, like, why is that all that important? Why is understanding the sympathetics are different than parasympathetics? Well, we actually induce different kinds of states by anesthesia, specifically spinals or epidurals. When we actually place an epidural, we actually begin to knock out the sympathetics in a way that you can see the same effect as if somebody were to get a spinal cord injury. So understanding this system will make you understand what happens when you do a spinal on somebody, and you won't be surprised, and you'll know how to treat it as well. Anyway, so parasympathetics originate from the spinal cord, and the brainstem and the brain stem and the spinal cord at the sacral level, and then it goes out to a peripheral ganglia, which is very near the organ. Okay, that peripheral ganglia means that it has another nerve body. Remember, a ganglia is a nerve body outside of the central nervous system. It's no longer a nuclei, now it's called a ganglia. Okay, so it's another nerve body, and that nerve body then sends another axon to the organ that it wants to have effect on. Now that's nearby, which is good, and the other thing that's maybe not so good about it is that it's demyelinated. It is an unmyelinated fiber. So if you're using an unmyelinated fiber for a short distance, you're not going to affect the response very much. Okay, you're not going to affect the electrical signal. But if you make that axon long, the electrical signal tends to be more diffuse. It tends to be a little bit more difficult for it to arrive at the location with its proper amplitude. But for parasympathetic, for such a short distance, it arrives just fine. Okay? And the secondary neurotransmitter that's released at that nerve ending, or that axon, is also acetylcholine. Okay, so both your parasympathetics are both acetylcholine receptors. Okay? Now, what's interesting about this is that they're not nicotinic receptors like the skeletal muscle, but they're muscarinic receptors. Okay? So they're muscarinic receptors. Now, the sympathetics, on the other hand, the first neurotransmitter that they send out goes to a what's called a paravertebral ganglia, okay, which are right along the body or the vertebra of your spine, from the thoracic to the lumbar area. So the actual intermedial lateral tracts that send out an axon, they go immediately out of your spinal cord directly to this area that's in front of your spine, outside of the actual bone encasement. Okay, and it's called the paravertebral ganglia. Okay, and that first receptor neurotransmitter is acetylcholine. From there, it sends out efferents. Okay, they go out from there and they run along the peripheral nerves. Okay, and those are unmyelinated fibers. So if you have sympathetics all the way down to your skin, that's a long way from here to my chest all the way down to my hand. That's a long way away. And that's all unmyelinated fibers. Okay? So sympathetics or unmyelinated fibers are going a long way. Okay? So as a consequence, you can get disease states that can affect the sympathetics a little bit more easily than the parasympathetics. Now these unmyelinated fibers, their secondary neurotransmitter is norepinephrine most of the time. Not always, but most of the time. Okay? It has no longer, at that point, muscarinic receptors. Now you have beta 1, beta 2, alpha, or alpha 2 receptors. Okay? So you have 4 different kinds of receptors that the norepinephrine can bind to. The other thing that the spinal cord also leads via sympathetics is that it has a backup system. It has an emergency system in place. Okay, that emergency system originates right around T6 down to around T8. Okay? And that emergency system basically sends a afferent out directly to the adrenal medulla. Okay, this is a myelinated fiber going all the way straight out, all the way down to the adrenal medulla. Okay? It bypasses the paravertebral ganglia, goes right to the adrenal medulla, and activates it to release epinephrine and norepinephrine under situations of high stress. Okay? Now, we know that exists constantly because if you do an anesthetic, when you put somebody to sleep, you're actually suppressing the system. Okay? You are basically inhibiting sympathetic discharge. That's part of your job. Okay? When people tell you, oh, pain doesn't kill you, that's not true. Okay? Pain can kill you. Okay? If you give somebody a big incision without having them asleep, it hurts, and not only that, it starts cranking up the sympathetics. And if you're not in good health, you'll have a heart attack. Okay? So pain can kill you. And when people tell you, well, you know, I'd rather just give a little local and the patient will be fine, that's not the same as giving a good general anesthetic. Okay? There is a reason for what we do. Okay? In the old days, people would die from just some of the procedures that were being done on them before anesthesia was available. Patients would just die from shock. Okay? What they were doing is the heart was going up to 150 to 160 heart rate, would fibrillate, and that would be the end of it. Okay? Because the person didn't have a good coronary blood flow. Okay? So these kind of things you want to avoid as much as possible. Okay? One of the things that we know is that if you give a good anesthetic, let's say you have somebody deep, okay, when you start the incision, you can watch your watch. And within 30 seconds, even if you're really suppressed, you should see around a 10-15% increase in heart rate. That's normal. That's what you want to see. That means that's where you should be at. If you're beyond that, if you're a minute into it and you still haven't seen any rise in heart rate or blood pressure, either the patient's on beta blockers or the patient's way too deep. If the patient's way too deep, then you got to back off because you're basically suppressing it so hard that you're not getting any response. That's not good either. You want to suppress it, but not to knock it out completely. And the last thing is if you see the incisions made and the person's heart rate goes up immediately, that's a bad sign. That means the person may be awake. Okay? So that means you're really way too light. So make sure that your vaporizer is full. If you have nitrous oxide, the likelihood that person have a recall is almost zero. Okay? But if you have only oxygen and fluorine and you forgot to fill the vaporizer, even though you have it at 2%, doesn't mean you're delivering 2% isoflurane. You could be in trouble. Okay? And that's how people get recall. All right? So your sympathetics give you a lot of information in the operating room, and you're also you're constantly trying to maintain them to a certain point. There's only three things that maintain your blood pressure. Okay? One of them is the sympathetic nervous system, okay, which is the only reason that you're vasoconstrict. There's no parasympathetics to your blood vessels. Okay? The other one is the renin-angiotensin system, okay, the vasopressin system, okay, is the third. Okay, so those are the three systems that you have in place. And the vasopressin system is also the antidiuretic hormone system. The vasopressin and antidiuretic hormone is the same thing. Okay, just that it's in very high levels. That's why they switched the name. Under normal circumstances, ADH is so low that it doesn't really have any effects on the blood vessels. Okay, but under times of stress, it may. Now, the master control center for the sympathetics and the parasympathetics mostly are hormonal. The hypothalamic center for the parasympathetics. Okay, that's your anterior pituitary. Okay, it acts on the parasympathetic action, releasing certain kinds of hormones to try to protect or basically put you in what's called a anabolic state. Okay, so when you're looking at the parasympathetic system, it's trying to let you go to sleep. It's trying to let you build up. Okay, so it's an anabolic system. The sympathetics, on the other hand, are the flight system. It's made to make you run, to hold fluid in, to keep you alive, okay, under times of severe stress. On the other hand, parasympathetics will make you sort of relax, sort of kind of cool down, not want to make you work, heart rate starts to slow down, everything to make you sort of want to fall asleep. Okay? The parasympathetic system includes the release of things like adrenocorticotropic hormone, okay, thyrotropic hormone, somatotropic hormone, follicle-stimulating hormone, and luteinizing hormone. All these are important for anabolic mechanisms as well as development of children. Okay. Posterior pituitary, on the other hand, is involved with sympathetics indirectly. It secretes pretty much high doses of either antidiuretic hormone, which is also known as vasopressin, okay, which is responsible for the kidney from inhibiting the release of water. So in other words, it holds water in, and that helps maintain volume in a patient who may actually be bleeding at the time. And the other reason that the posterior pituitary is also important is in pregnancy for the release of oxytocin. Okay, oxytocin or pitocin is released by the posterior pituitary at the time of delivery to keep the woman alive and from hemorrhaging to death. The neurons that you're looking at are preganglionic or always myelinated in all systems, both sympathetic and parasympathetic. The postganglionics are all unmyelinated. The difference is that the postganglionics for sympathetics are long distance away, versus the parasympathetics are only a short distance away from the organ system that affects. Now the two divisions, okay, you have sympathetics are fight or flight, and your parasympathetics are rest and relaxation, we just talked about. Now this is a nice diagram breaking it down for you to show you where the sympathetics and parasympathetics are located at. Okay, in this picture, they're showing you here. Okay, this is the gray from the parasympathetics. Okay, right here. Okay, and they're splitting up the sympathetics, posterior pituitary here. Okay, and then the anterior pituitary is part of the parasympathetic system. But they're showing you here nicely in this gray kind of strip pattern this main system that's involved with parasympathetics. Now the parasympathetic that's the most important one that you'll learn over and over again is the vagus. Vagus is the most important for the overall effects of the organs in the body. Okay, it affects the heart, lungs. Okay, it does affect the GI tract. It also goes down and helps control to a certain extent the small intestine and the ascending colon. It is not responsible for the transverse colon or the descending colon or the rectal area. Okay, that's all part of the sacral nerve roots. Okay, one of the reasons that we check anal tone in a traumatically injured patient is to make sure that the sacral cord is still intact. Okay, if you lose anal tone, then that person has basically had a significant spinal cord injury anywhere between the sacral area to the brainstem. Okay, so it could be anywhere, but at least it gives you an idea that you do have disconnection to the sacral nerve roots. Okay, they're also important for relaxation or action on the bladder, which we'll talk about another time. Now, the reason we talk about this too is because sometimes when we give certain agents, we actually induce the person to have diarrhea on the anesthesia table, on the OR table, and they'll always blame it on us, which of course it is due to the medications we just gave to the patient. Now, one of the other things that is shown here is the thoracolumbar area, okay, which is a sympathetic nerve chain. The thoracolumbar area originates from around T1 all the way down to L2. Okay? Once you're below that, you're basically no longer in the spinal cord. L1, L2 is where the spinal cord stops. From that point on, it's nerve roots, okay, called the cauda equina. Okay? So really the point where you should put a spinal in an adult is below L1, at least below L2 in children. Okay? And you should always do that. In epidurals, you can put it, usually you should stay down lower than that as well. But if you do have to do an epidural up higher, you've got to make sure that you don't get into the CSF space, because then you can induce a spinal cord injury. The sympathetics are important in the sense that they're broken down into these parasympathetic paravertebral ganglia. Okay? This is the first originating point where the actual preganglionic fibers go to. Okay? And from there, these axons then go from these nerve bodies all the way to the organ that it wants to affect. Now, what we do is we can break it up into different areas. The first one I will talk to you about is as you go from bottom up. Okay? If you look at the celiac plexus, which is around T6, okay, T6 through T8, the celiac plexus is where the celiac artery comes out. It's one of the first branches of the aorta that gets into your abdomen. Okay? It's the blood supply to your stomach, your liver. Okay? If you have a spinal cord injury below that, you usually don't get hypotension. Okay? You will maintain normal blood pressure unless you have hemorrhaging from somewhere else. Okay? Because it just vasodilates your legs and your lower GI tract. So it's not enough to be an impediment to your blood flow, and your blood pressure will stay steady. If you get to a T6 level, on the other hand, that means you're going to have a celiac plexus is not going to work properly, and it causes vasodilation to the stomach, the spleen, and the liver, as well as the rest of the GI tract. and then you're going to get hypotension. Hypotension that may be very, very profound in the 60s, 70s, with an increase in heart rate. The heart rate is still maintained because the sympathetic chain above that is still active between what's called the T1 through T4 cardiac accelerator fibers. Okay, so what actually runs your heart is, what makes it go faster is in the T1 through T4 area called the cardiac accelerator fibers. If you get a T2 or T1 spinal cord injury, you will see a very severe bradycardia and hypotension. That's a worse place to be. Okay, the reason it's such a bad place is because when you give these people indirect acting agents, okay, you may get no effect at all. Okay, if you give this person atropine to make the heart rate go up, guess what happens? Nothing. Okay, because there's no sympathetics to take over. Atropine is an anticholinergic that blocks the parasympathetics, and the sympathetics then take over. If you don't have sympathetics, it doesn't work. So if you have somebody with a spinal cord injury at T1 level, or you have a person with a spinal going up to T1, you may have the same effect. You may say have severe bradycardia with hypotension that is untreatable almost. Okay? The only thing you can use to treat it is directly acting agents like epinephrine. So if you get into a situation where you're in hypotensive shock, for severe bradycardia, epinephrine should be your first line of medicines that you should pick up. Now, the sympathetics basically mobilize energy stores in times of need. Okay? It also is a catabolic system, and when we do surgery on anybody, everybody's catabolic, simply because you are activating the sympathetic nervous system. And the only way we can ameliorate this is by shutting down the pain response completely, and that's hard to do. We can do it partially well with epidurals, okay? And we've shown this in clinical studies, but it still doesn't change the outcome at times. Now, this sympathetic innervation receives innervation from cell bodies located in the first thoracic through the second lumbar area. It's called the thoracolumbar division. And then it sends out to the sympathetic paravertebral ganglia. Okay? This is the, let's see which one is this one. Okay, this is combined. What it's showing you here is this is the sympathetics. It's showing you the origination point, okay, going to the paravertebral ganglia, okay, which is right along here. They don't show the bony vertebral body, but there's a chain on each side of the actual vertebral body. If you look at the vertebral body, you can actually draw it out like this, okay? I'm going to show you this picture. Maybe it'll make more sense. Okay, this is the world. Okay, and on that world, you're going to make a church. You're going to have the dens, okay? Then you're going to put the transverse processes. Then you're going to put the lamina, which is a roof. And on that, you're going to put your church sign, whatever it is, okay? So that's your spinous process, okay? Now, inside the church is the most important structure, which is what? Spinal cord. Okay, spinal cord is going to get afferents from here and efferents going out. Okay, when it sends out the efferents, it comes into a common nerve. See how it comes together? Okay, but then it sends this nerve out this way, and it comes out. Let me make the drawing a little bit different. Make the green the efferents back. Afferents back. Okay, so the red's going to be the efferents out. Okay, this is going to go back to here, and that's going to be a nerve body it's attaching to. That's called the paravertebral ganglia. Okay? So they're right along the vertebral bodies, right anteriorly to them. Okay? Now the reason this is important is if you decide to do some pain work, you can actually isolate and knock out only the sympathetics by putting a needle right along to that area, and then you inject it right next to that area, and you shut off the sympathetics going to that organ system. Okay, so you can do different levels and knock out just the sympathetics without affecting the motor at all. Okay, as long as you're just staying in the paravertebral ganglia. Okay, the motor, which also originates, let's make the motor, let's say black. It's also coming out like this. It keeps going down. The green, remember, is coming back from the sensory. and then the red comes back out like this. Okay, and this is unmyelinated fibers. So it comes in to the preganglionic, binds to a cell body via the main neurotransmitter being acetylcholine, and then it leaves, comes around and hooks up to the nerve again, and it goes out as the efferent component, which its neurotransmitter, when it gets to that organ, is being a norepinephrine. Okay? Does that make sense? Okay. Please go over that. It's really critical for you to understand. Okay? The parasympathetics work from the brain, okay, go to a nearby ganglia, and then it goes from that point to the organ system. So that's near. It's not anywhere close to the spinal cord at all or spine at all. Whereas the sympathetics originate at the T1 through the L2 level all the way down. Okay, we have the intermedial lateral tracts, which when you look at the spinal cord, okay, you're looking at, this is where the motor's at. This is where the sensory's at. So we'll make this motor here. And this is where the sympathetics are at. That's the intermedial lateral tracts. Okay? So when you're sending out information to, let's say, to a muscle, it's got an autonomics connected to it. It goes out this way. The motor follows with it. And then it goes to the paravertebral ganglia for the sympathetics. The motor just bypasses that completely. So you can do an isolated block on somebody by doing a paravertebral block and just knock out the sympathetics. Okay? If it doesn't make sense just yet, it'll come back. We'll come back and hit this over and over again. Just make sure that you understand some of the basics right now for this test, which is understand the difference between sympathetics and parasympathetics. Know that one is a system that shuts you down and makes you go to sleep. Another one that makes you awake and aware and makes you ready to run and fight. So it makes your heart rate increase. Versus the parasympathetics slow you down, make your heart rate go slow down. Now sympathetics sympathetics only control blood vessels. There's no parasympathetic control of blood vessels. So vasomotor tone is not maintained by parasympathetics. It's purely a sympathetic action. So that's why when you give atropine, there's no effect on blood pressure. Okay, atropine is anticholinergic. So what it does is it shuts down the parasympathetics. So as a consequence, you don't see an increase in blood pressure unless you see an increase in heart rate. Okay, but as the actual vasomotor tone does not change at all with atropine. Okay. Sympathetic activation leads to two things. It can cause contraction of arterial smooth muscle, which can cause vasoconstriction, increase peripheral vascular resistance, and increase your blood pressure. And sympathetics can also activate the adrenal medulla, releasing epinephrine and norepinephrine, which increases the strength of contraction of the heart. Okay. Sympathetics also go, of course, to the heart, okay, and via beta-1 stimulation causes the heart rate to activate. Okay. The sympathetics also innervate the ventricle, whereas the parasympathetics do not. The parasympathetics have no effect on ventricles at all. Okay. The only thing the parasympathetics bind to in the heart is the actual SA node and AV node. So they actually can decrease heart rate, but they do not affect the actual contractility of the ventricle. Only sympathetics can increase contractility of the ventricle and increase heart rate. The parasympathetics basically function to conserve and restore energy. Okay? They receive innervation from cell bodies located in the cranial nerve nuclei in the sacral region of the spinal cord. Okay? The preganglionic travels ganglia close to the organs, they innervate. Okay, this is the parasympathetics. You can see how they work. These are myelinated fibers that you're seeing here. Okay? And they get all the way almost to the organ system before it sends out a small demyelinated fiber to the effect. Okay? Now, parasympathetics have not only information that they send out, but they also have information that comes back in, which we call afferents. Okay? So remember, you don't just separate these things out as simply being effectors. They also are afferent information that comes back with them as well. So it gives you information about how that organ system is functioning. Now, you have your, this is another picture showing you what I was talking to you about before. Okay? This shows you that you have your dorsal root ganglia, okay, which are the peripheral nerves that are coming back in. They actually have information that's the afferent is coming back in, and it goes to a dorsal root ganglia first, okay? And then it goes back to the cell body in the afferent location up here. Then you have your intermedial lateral tracts, which is located here, okay, which just sends out the sympathetics. The sympathetics come out and they're called white rami, okay? The reason they're called white rami is because they're myelinated, okay? They're myelinated, okay? So white meaning they're myelinated. And then they go into the paravertebral ganglia, okay? And once they exit from there, they're unmyelinated, it's also called gray rami. Okay, if it goes directly back to the peripheral nerve and it goes to the effector organ, that's fine. The other thing they added in this picture was the nerve that goes directly to things like that are white rami still, that are like the adrenal. Okay, the adrenal just basically stays myelinated all the way out. Okay, and in some situations like the splanchnic nerve, you can go out to what's called prevertebral ganglia as well, and then bind and then cause unmyelinated fibers from there. Okay, so there's different systems that are in place for the sympathetics. But overall, what I want you to sort of understand is that the end effect is that you have a long distance from the myelinated fibers. Okay? The only exception to that is the actual adrenal medulla. The adrenal medulla has a myelinated fiber that goes all the way to it and causes direct stimulation using acetylcholine as its primary neurotransmitter. That's the only exception to the rule. Okay? The secondary effects, which is it's a hormonal effect, is a norepinephrine being released from the adrenal medulla, affecting the actual target organs, which are, of course, the norepinephrine binding, which is at the heart rate. Now, the autonomics can be broken down into this system. Okay, the eyes. The reason that eyes are going to try to do something is to basically improve your eyesight. So sympathetic in function is going to vasodilate you. Pupillary dilate you, which is called mydriasis. Okay, which dilates your pupils. Okay, parasympathetics on the other hand is going to try to make you go to sleep, so your pupils are going to actually get smaller, which is called miosis. Okay, it actually contracts the ciliary muscle. The lacrimal glands are going to be increased when you talk about parasympathetics, because parasympathetics is responsible for eating, okay, and for states of relaxation. So you'll see that the person's salivary glands will begin to be stimulated with the parasympathetics. Okay? On the other hand, sympathetic function increases the effects on the sweat glands. Of course, you think about it, if you're going to increase heart rate and respiratory rate, that means you're going to increase heat production in the body. So you want the sweat glands to be able to secrete and cool you down. Okay, so sympathetics actually increase sweat gland production versus parasympathetics do not. Okay? Heart rate increases with sympathetics. It decreases with parasympathetics. The blood vessels will constrict. There's no effect at all with the parasympathetics at all. Lungs dilates the bronchial tree, which is kind of important. On the other hand, parasympathetics have very strong bronchoconstriction properties, and sometimes we actually give drugs, which are called anticholinergics, such as atropine, or usually what we call atrovent. What's the name of it now? I remember in a second, but it's an atropine-like derivative that we use to reverse the effects of bronchospasm in children as well as adults. And GI, it inhibits motility and secretion, so anytime you increase sympathetic function, you really don't want your GI activity to increase. It doesn't make sense, but the parasympathetics on the other hand do that. GI sphincters will contract versus parasympathetics will actually relax it. The adrenal medulla is being stimulated directly by reducing epinephrine, and there's no significant effect at all with parasympathetics. The urinary bladder will contract with parasympathetic function. With urinary tract, this is very controversial. Different people give you different descriptions. Okay, there's different situations where people will actually urinate themselves due to high sympathetic outflow, versus some of the books say that it constricts or impairs the urinary system, which it does at times. So those are the kind of things that I expect you to know is just the first few that I talked about, which is the blood vessels, the heart rate, know about the eyes as well, because that's an important part of it. Neurotransmitters that are released, the sympathetic preganglionic fibers are all acetylcholine and cholinergic receptors. Okay, the sympathetic postganglionic tend to be norepinephrine and adrenergic receptors. As far as the parasympathetics, pre and post are both acetylcholine and cholinergic receptors. What you see here is a breakdown. Okay, the receptors that we see in both parasympathetics and sympathetic preganglionic or muscarinic receptors. Okay, books have it different, and sometimes in different literature. So I don't really ask you that in the exam, but I do want you to know is the main neurotransmitter being released is acetylcholine. Okay. For the sympathetic postganglionic, it's norepinephrine, except for the sweat glands, which also release acetylcholine. And so there's always an exception in medicine. So sweat glands are acetylcholine based. Okay. Muscle, on the other hand, is somatic. Of course, is acetylcholine with nicotinic receptors. Okay. The sympathetic postganglionic receptors are alpha 1, beta 1, alpha 2, or beta 2, and we'll talk about those in more detail. Okay. When you're looking at the actual receptor coupling, most of the sympathetics and parasympathetics are what's called G-coupled protein receptors, okay, which are important later on. We asked you to sort of talk about that in the next year. Okay. It's a little bit on the higher end for now. Just understand that the receptor itself does not cause the direct effects inside the cell. It's a secondary messenger that causes the direct effect, and that secondary messenger is activated by what's called a G-coupled protein receptor. Okay. And there's a huge whole science in this area that's really blown up in the last 10 years. The length is also important for you to know this. This is the kind of stuff that I would expect you to know on the test. Long to peripheral ganglia, which is short in sympathetics. Myelination, you know which one's myelinated. Location is also important, and response time. Fast, pretty much, and the postganglionics are slow for response time, so that's why there's a little delay. One of the reasons that we have direct connection between the sympathetic preganglionics directly to the adrenal is because it's fast all the way. Fast, and then it gets to the sympathetic adrenal medulla and then causes the effect, which is still a little bit delayed because of blood flow, but it's still pretty very quick. Now, the last thing we'll talk about is aging in this section. Basically, aging decreases the number of neurons, so you get senile plaques. And you also will develop neurofibrillary tangles. The reason this is important for you is that we're going to be taking care of 80-year-olds here in Naples. Okay? If you read some of the textbooks, they'll tell you in the old days, they tell you never to put somebody to sleep that was 80 years old, and we routinely do that all the time now. Okay? So what people couldn't do 30 years ago, we do routinely now. You have to understand the differences between a young person and putting somebody who's 80 years old. Okay, the natural cell mass number drops significantly, so anesthetic equivalency also is very sensitive at old age. Okay, versus you have to know the difference, because if you put somebody that's 20 years old and all you've been putting to sleep is 80-year-olds, then you're all of a sudden surprised when you're having to give 4 times as much of narcotic and you're cranking up your anesthetic agents just to keep them on the bed. Versus an old 80-year-old person, if you do the same thing, you'll end up killing them. So you've got to know the differences. Tests that we can actually do for nervous system function are varied, okay, and it continues to improve over the years. We have skull and spine x-rays. We have CTs that are becoming incredibly high resolution over the years. What used to take us an hour of actually doing a CAT scan will take us 30 seconds now. It's a scanning, so it's hugely improved. The amount of computing power now that a CT, basically a CT is an x-ray taken in multiple different axes, and then what it was taking so long was the actual computing power. The computational ability of the machines would be so delayed that it would take an hour to process. But with the new computer processors, now we're getting things that are 3-dimensional. We can actually develop a 3-dimensional model in 30 minutes. And in 10 years from now, that computer model will be 3D immediately. So it's just a matter of just getting the computers at a higher speed. We also have PET scans, which are called positron emission tomography scans, which can actually give you an idea exactly what portion of the brain is doing what. Brain scans, cerebral angiograms are also very helpful. And you'll be exposed to cerebral angiograms because you'll actually be sedating these people in our radiology labs to help the stroke victims. We actually are doing not so much here as we wanted to, but I think the future lies in stroke therapy to certain degrees, to interventional, just like interventional cardiology. There will be interventional radiology in the sense of taking care of stroke victims. Some centers that are pretty ahead of the curve are doing this right now. They're actually putting in stents or putting plot busters in people's brains, and you can see that tremendous improvement. I've also seen them die right in front of you as well. If you wait too long and you give them a clot buster, then they hemorrhage into their brain and they die very rapidly without you being able to do very much. But it's out of that remains severely, damaged state, or going back to normal neurological function, and that's something that you have to think about. EEGs, evoked potential, cerebrospinal fluid, all these things you will know about to a certain extent. You'll know the limitations in all these scans, and you'll know how to use them in the operating room. Some of them we actually use in the operating room, like EEGs, evoked potentials, both somatosensory and motor evoked potentials. You'll have to know the difference between the two. You also will know the differences in how anesthetic management will actually change the actual reading of these tests, and how that's important for you in the sense of how you're managing the case. The last part is the nerve injury and regeneration. You have Wallerian degeneration occurs distal to the cut, okay, which means that when you cut a nerve, the nerve will not grow back unless the actual cell body remains intact. If you lose a cell body, the nerve dies and that's it. It doesn't come back. Okay? If the nerve body is not injured but the axon's cut, then what will happen is the distal end of it will swell. It will actually develop hypertrophy. The myelin sheath shrinks and disintegrates, and the axon portion degenerates and disappears. Proximal to the cut, on the other hand, okay, the swelling, dispersal, and distal substances, the cells increase their metabolic activity, and the new terminal sprouts project from the proximal segment. Now, if you can approximate the myelin sheaths together, okay, it will try to find its way back to the original point. Okay? So nerves can regrow back in their peripheral system. Okay? It just takes a long, long time. Okay? It's like 0.2 millimeters per day. So that's a long time for a nerve to regenerate. Okay? And this is what it actually does. This is a nice picture. If you cut the nerve right here, okay, this happens in the operating room. You do cut nerves every once in a while. And the pickup is that the surgeon will ask the patient to move their hands afterwards. If they can't move their finger, then you've got to go back to the operating room and put that patient to sleep and find the nerve. Okay? What you'll do at that point is it's not that you're going to fix the distal end of it, but if you can find the point of injury and then resuture this together so it approximates, then when this happens again, okay, the nerve will actually find its way down the axon and be able to regenerate the myelin sheath again. Okay? If you have it cut and it's away from it, then the nerve bundle will just form a ganglia here. It's an extensive axon bundle, and it'll be very painful for the patient, and they won't have any function to the muscle at all. So the muscle will atrophy as a consequence. So you don't want to be in that situation. If you do get a nerve injury, you want to pick it up early so you can go back and fix it, at least as much as you can.